Good afternoon, good evening, good morning, everybody. Thank you so much for attending this webinar. My name is Blair Green. I am a physical therapist in Atlanta, Georgia, here in the US, and I am a specialist in pelvic health and women's health. I'm an instructor for Myopain Seminars. I've been practicing for about 20 years now, and I've been teaching this dry needling for pelvic floor dysfunction for Myopain Seminars for the last about 3 years. It's been a great course. It was one I designed myself, and I've been teaching myself. I've been using dry needling in my practice now for over 10 years, probably about 11 or 12 years at this point. And so this is something that's very near and dear to my heart, and I'm really glad you could join me today to hear a little bit more about dry needling for pelvic floor dysfunction. So just to clarify, put your questions and comments in the question box and we will get to them. We're going to try to keep it to about an hour so that we're respectful of your time. But if you have any further questions, I can always stay on for a few minutes at the end as well. So anyway, like I said, we're going to get started. This is, again, it's a little bit about dry needling for pelvic floor dysfunction. So what we're going to spend the next several minutes talking about is some of the evidence that supports the presence of myofascial trigger points in and around the pelvic floor, some of the conditions that involve the pelvic floor muscles, and maybe why we would want to use dry needling as an intervention for these muscles. And at the very end, we're going to talk a little bit about some clinical correlations. So some common pelvic floor disorders, and some of the muscles that typically where we find trigger points on a clinical exam, and some of the areas that we would treat from the clinical standpoint. And I will leave you guys with one technique I strongly recommend if you are not already doing dry needling, or if dry needling is not legal in the state where you live, you should not perform this. So I'll put that disclaimer out there. I just want to give you one little kind of clinical pearl to take with you as you leave this webinar, and hopefully get so excited that you will want to learn even more about this subject. Before we get started, a couple housekeeping things. Just wanted to put up here the schedule of the upcoming courses, webinars, that Myopain and Eureka Seminars are hosting here. The next one is going to be next week. It's another pelvic health lecture by Colleen Whiteford, orthopedics and pelvic health. And so while this lecture is focused more on the internal components of the pelvic floor, hers is going to focus more on some of the external muscles and some of the fascial connections around the pelvic floor. The following week, Jan Dommerholt's going to be doing a presentation on whiplash. That'll be followed by a presentation on bruxism, and then finally, July 7th, a presentation on tinnitus as well. So I think that's going to be the remainder of the webinars in this series. This is every Tuesday from 5 to 6, so you can sign up in advance like you did for this presentation and then just continue with these. As a reminder, these webinars are free, so it's a nice advantage that we have provided for all of you. But in lieu of the course registration fee, Myopain Seminars is collecting donations. This is our way of just saying thank you and giving back to a population that's hurting during this difficult time of COVID, where we are in our homes. A lot of people aren't working, and we're just trying to stay in touch with our community. So as an organization, we have decided to benefit the No Kid Hungry campaign, and this campaign connects kids in need with nutritious foods and teaches their family how to cook affordable meals. It also their priority for the No Kid Hungry campaign is really to help end childhood hunger. So any amount you can donate, from $1 or whatever you feel comfortable donating, would help make an impact. After this webinar, you will receive an email with a link if you are interested in making a donation. We would really appreciate that, and we thank you in advance for doing so. All right, so now getting on to our presentation. The first thing I want to bring up is who benefits from knowing how to perform dry needling in the pelvic floor. So from a clinician perspective, which clinicians is this really relevant for? Well, I think the obvious is clinicians, PTs, who are already treating pelvic floor dysfunction. If you're already doing manual techniques, these dry needling techniques can really be beneficial in terms of helping you treat trigger points, giving you another tool in the toolbox, giving you something else to provide your patients. But I would also say that any physical therapist who treats low back pain may also want to consider learning about the pelvic floor muscles, about pelvic floor dysfunction, and treating these regions. In addition, any PT that treats hip pain. So you're probably thinking, wow, I've never looked at the pelvic floor, but I treat hip pain. So we're going to talk about maybe why the pelvic floor muscles are relevant to PTs who treat hip pain. PTs who treat women, we know that pelvic floor muscle dysfunction affects women more than men. So we find that often in women's health conditions, especially any woman who's been pregnant or has given birth, probably has some reason that you would want to examine their pelvic floor muscles at some point and may benefit from dry needling. And then in addition, PTs who treat men, because pelvic floor dysfunction is not exclusive to women. So it does, even though it does affect women more than men, there are particular conditions where we can really help men as well. One of my favorite quotes, and this is by physical therapist here in the US, Ramona Horton, she says, pelvic floor is orthopedics in a dark cave. And what I want you to think about here is the role of the pelvic floor in treating the whole person. So traditionally, when we think about the pelvic floor, we kind of think about it separately from other parts of the body. So often it's not integrated into our treatments. But if we really think about what's going on in the pelvic floor, and hopefully this is the message I can get across to you in the next hour, the pelvic floor muscles are exactly what I just said. They are muscles. They are part of our musculoskeletal system, just like the muscles in our hips, in our upper extremities, in our back, in our abdomen. The pelvic floor muscles need to be treated as part of treating the whole person. So a lot of the principles that we take toward managing pelvic floor dysfunction is not very different than what we are seeing in patients with other orthopedic conditions. And if you're not already screening for pelvic floor dysfunction, if you are working in an orthopedic clinic, I highly recommend that at a minimum, you consider taking a course just in pelvic floor basics. And there are several courses out there in several ways you can start to learn about the pelvic floor, even if you don't want to be a pelvic floor therapist. So looking at the anatomy and really just operationally defining the pelvic floor so you can understand what I'm talking about, the pelvic floor is comprised of all of the soft tissue structures and all of the organs that sit between the abdominal cavity and the bottom of the pelvic floor, which is actually the pelvic floor muscles. So when we talk about the pelvic floor, we're not just talking about muscles. As you can see in this picture over here on the left, you can see the pelvic floor muscles, and so you appreciate this perspective, it's a sagittal cut. So this is the anterior portion, the pubic symphysis right here with the sacrum posteriorly. And you can see that these pelvic floor muscles sling from the front to the back, so from anterior to posterior. And you can see that here on this picture on the right, where this is your pubic symphysis. Coccyx is back here, and these muscles are running from anterior to posterior. They also run laterally, so they make literally a hammock on the bottom of the pelvis. But interwoven with these muscles are nerves, tendons, fascial structures, and then the genitourinary organs. So we know that in the females, the genital organs are internal, where on the males, they are external. But we also have to consider other organs such as the bladder, the prostate, the intestines, the rectum, which also sit in this region. When we're talking about dry needling, we are talking specifically about these muscles in the pelvic floor. The pelvic floor muscles, from an anatomical perspective, the best way to think about them, and I'm going to give you a little functional way to think about them also, is they're organized in layers. So if we think about it moving from superficial to deep, the most superficial layer, there's 3 layers, and the most superficial layer is this one right here. This is what's known as the urogenital triangle. So the muscles in the urogenital triangle include the bulbospongiosus or bulbocavernosus, and this is a female lithotomy position, so you can understand this view. But you'll see the bulbospongiosus kind of runs just off of midline. This muscle is also present in males. It actually runs from the perineal body, which is a fascial structure right here, situated in the middle of the pelvis. And in males, it actually runs up into the base and the shaft of the penis. In women, it comes superiorly up into the bulb of the clitoris. My apologies, let me go. The second muscle is what's known as the ischiocavernosus, and this muscle runs from the crus of the clitoris. It comes laterally and inferiorly actually to the ischial tuberosity. And what you can appreciate from this view is it runs parallel to the ischiopubic ramus right here. So this muscle is very easily palpable, even from an external perspective. The bulbospongiosus and the ischiocavernosus, if you really want to palpate them and you don't have training or your patient doesn't feel comfortable with an internal palpation, those muscles you can actually palpate externally, as well as this one, which is the superficial transverse perineal, and this is one side and the other side. Also in this first layer is the external anal sphincter. And so that is a muscle that we can treat with dry needling as well, even though it's situated a little more posteriorly from an anatomical perspective. If we peel away that first layer, just deep to that is a second layer, what's known as the urogenital diaphragm. And you can see that right here on this netter slide. The urogenital diaphragm consists of a muscle called the deep perineal muscle, which sits just deep to the superficial transverse perineal muscle, and then the muscles around the urethra. So what are known as the compressor urethrae and the urethral sphincter, the external urethral sphincter. So these are the muscles that control urination. The first layer muscles also play a role in urination, especially in males, but they also play a role in sexual function. So when we're dealing with arousal and orgasm, these are the muscles that we're really concerned about in sexual function, are these first layer muscles. The third layer, I think, is what most people are familiar with when they talk about the pelvic floor. And you can see it here. What I want you to keep in mind from this perspective is this is the anterior portion of the pelvis. But remember, these muscles run from posterior to anterior. So even though you can't see the full range of motion, and I've got some other pictures later where you will see it, these muscles, which are known as the levator ani muscles, run from the pubic bone, they run from the ischial tuberosity, and they come posteriorly toward the coccyx. So this is that third deepest layer and what we typically think of as the pelvic floor. There's also another muscle there, what's known as the coccygeus, and that attaches directly to the coccyx as well. That muscle is what has evolutionary been the tail wagger muscle. So it's the muscle that if it works unilaterally, it brings your tailbone from side to side. Working bilaterally, it can actually flex the tailbone under. So these muscles in the third layer play more of a supportive role. So if we look at this slide, I've grouped them into two different functional groups so that you can understand when your patients are talking about maybe some different symptoms they're having, it'll clue you into maybe where you need to look first. These are not exclusive, so it's not like just because somebody has more of a supportive problem, which is typically a prolapse or pelvic pressure or perhaps even some deep pelvic pain, you're only going to look at these deeper muscles, but it's important to remember that you need a place to start, and so this will clue you in on maybe which of the primary roles these muscles have. The more superficial muscles, those layers 1 and 2, tend to play more of a role in genital function, so sexual function and urinary function, as well as anal sphincter control, which I didn't put on there. But these are what's known functionally as the urogenital diaphragm, and they have more of this urinary role. The deeper layer, which is made up of not only that third pelvic floor muscle layer, but also two muscles you may already be familiar with, the obturator internus and the piriformis. These muscles make up what's called the pelvic diaphragm. So now we're starting to pull in some other muscles. So it's not just about these pelvic muscles that contribute to pelvic floor dysfunction, but muscles that are situated outside of the pelvis. And you can see that here in these two pictures. So the significant things to point out here, if we look on the left, this is highlighting in green the obturator internus muscle. So the obturator internus is actually making up that lateral side wall of the pelvic floor. And we're going to come back to this later in the slides. But what I want you to appreciate is that there is an internal portion to this muscle that we traditionally think of as a hip rotator, that it does actually sit inside the pelvic floor. And what you can appreciate here is this white line. This is what's known as the arcus tendinus levator ani. Sometimes it's abbreviated ATLA if you see that written somewhere. But the significance of it is it's a tendinous attachment. It's a collagenous structure that has two attachments to it, the obturator internus on one side and the iliococcygeus on the other side. So you have this connection of the hip muscles with the pelvic floor muscles and no bony landmark between them. So you can imagine from a neuromuscular standpoint that if there's any kind of issue with one muscle, it could very well start to refer to the other muscle or perhaps develop some secondary trigger points in this muscle. The other place that we see this in the pelvis is with the piriformis. So if you recall, the piriformis medially arises off the anterior portion of the sacrum. So it's running through the pelvis, it's going through the sciatic notch and then attaching to the greater trochanter externally. So this does play a role in terms of support and stability, and we're going to talk about the functions of the pelvic floor. We cannot forget about the obturator internus or the piriformis. Most recently, this was in 2015, there was a study done by, the authors were Cody and Futterman, and they looked at the relationship between femoroacetabular impingement in the hip and the presence of vulvodynia. So this was really a landmark study linking hip and pelvic floor dysfunction. They found in many of their patients, and they are, I believe, a gynecologist and a pelvic floor physical therapist, that many of their patients who were experiencing vulvar pain or deep vaginal pain were also had the symptoms of hip impingement. And they had MRI confirming the femoroacetabular impingement. And they found that in these women, if they had surgery to correct the hip dysfunction, in many of them, their pelvic floor symptoms went away. So they concluded that there was a direct relationship between the hip and the pelvic floor. This was also seen in another study by Baba et al. In 2014, where they actually looked at the presence of urinary incontinence in patients pre and post total hip replacement. And they found that after the surgery, many of these older patients who were complaining of urinary incontinence, their incontinence symptoms went away. And they felt that maybe this was because of this obturator internus muscle, that once the hip arthritis was dealt with through the hip replacement, there was no longer this abnormal input into the obturator internus muscle, and perhaps that's why the urinary incontinence was able to resolve. So when we talk about the pelvic floor muscles, we talk about them having four primary functions, and I always like to think of them as the four S's because they start with the letter S. So the first role is support. So the pelvic floor muscles are providing support for the internal organs. So like we talked about, those genital organs that sit internally in females, as well as some of the urinary organs, such as the bladder and the prostate and the rectum. So these muscles are providing support on the bottom of the pelvis to help those organs stay suspended where they need to be. They also play a role in sexual function, like we mentioned, including arousal, erection, and orgasm and ejaculation. So this is for men and women. These muscles are very significant in sexual function, so that we'd be remiss if we talked about sexual function and dysfunction and didn't mention the pelvic floor muscles. They also play, as we know, a role in continence control, and this is both urinary continence and anal continence. So they are help regulating when, how much, and ease by which we can eliminate both urine and feces. And then the fourth role, and this is the little Stonehenge-like structure over here, is the role of the pelvic floor in stability. So going to focus a little bit throughout the rest of this webinar on that role, because it's going to help you to understand the relationship between the hip and the spine and the pelvic floor, and maybe why we all need to consider treating the pelvic floor in most of our patients with myofascial pain. So one question we can ask is, why is the pelvic floor susceptible to trigger points? So if you think back to that very first slide I showed you, it said who can treat pelvic floor dysfunction, and I had a bunch of different PTs listed. The picture on the right was like a big jumbled up highway. And I always like to say all roads lead through the pelvis. So when we're talking about load transfer, whether it's walking, whether it's changing positions or participating in work or sport activities, or, for women who are working in the home with their children, lifting children, caring for children, cleaning the house, any type of movement that we do, load has to transfer from the top down to the bottom or from the bottom up to the top. And all load is passing through the pelvis. So the pelvis is a region of the body that is really susceptible to a lot of repeated trauma. And I use that word trauma very lightly, but even in the terms of the micro trauma that happens from repeated movements. So the pelvic floor muscles are on all the time. Pelvic floor muscles are 70% type 1 muscle fibers and 30% type 2 muscle fibers. So they are always working. They are a postural muscle, just like our deep multifidus in the low back, just like our deep abdominal muscles. They are constantly working to help gauge tone, and they work in a feed forward mechanism to help maintain spinal stability and motor control through activities. So muscles that are working all the time become very susceptible to trigger points, because the one reason we may develop trigger points is that our muscles are overworked. Other reasons may have to do with things that are specific to women, such as pregnancy and childbirth. So we know that when women go through pregnancy, it's 40 weeks of significant musculoskeletal changes, and then that's met at the end with the trauma of childbirth. So having to, whether it's a vaginal delivery, having to push a baby through the pelvis. So those pelvic floor muscles are working very hard during that time. And then the recovery from childbirth is another time when pelvic floor muscles might be susceptible to problems. We also can't forget about the chronic holding pattern. So if we think about especially our society here in the US, and it's funny, during the past few months of everybody working from home, I find that people are sitting a lot more. They're not getting up, they're not going out, they're not meeting friends for lunch. So we are just sitting at our desks all day long on webinars and calls just like this. So a lot of that chronic holding and sustained holding also may make our pelvic floor muscles more susceptible to developing trigger points. I always like to think about pelvic floor dysfunction as being intrinsic or extrinsic. So the way we can think about this is sometimes the muscles in the pelvic floor itself develop trigger points due to a specific pelvic floor disorder, which we will talk about. Sometimes the pelvic floor muscles develop trigger points because of things going on outside of the pelvic floor, and the pelvic floor muscles responding to that. So it might be a satellite trigger point. It might be an antagonist or a synergist of some other muscles in the body that are prone to dysfunction, which then may lead to dysfunction inside the pelvis. So it becomes very important that we are evaluating from the outside in and from the inside out. So I like to make sure that those of you who do treat the pelvic floor primarily, you're not just telescoping into the pelvic floor, but considering other structures. And for those of you who maybe have never looked at the pelvic floor, that maybe you stop with your next patient who's experiencing hip or low back pain and start to consider, especially in those where maybe they're not getting better or they're not responding the way you would think to your interventions, that perhaps there is a pelvic floor component that we need to look at. Remember what I said before, that one of the main roles of the pelvic floor is stability. So this picture shows the abdominal canister, or what sometimes we call the anticipatory core. It's made up of the diaphragm superiorly, the pelvic floor inferiorly, the transverse abdominis anteriorly, and the multifidus muscles posteriorly. So these are the muscles that are gauging control as we're moving through whatever range of motion or whatever activity we may be doing. These muscles are all working together to help maintain and moderate intra-abdominal pressure. So if we're already addressing other muscles in the core, we need to make sure that we're not ignoring the pelvic floor muscles. The pelvic floor and the diaphragm actually work together. If you're not already familiar with that, it's what we call the diaphragm pelvic floor piston. So what we find is functionally when we inhale, so remember with inhalation, the diaphragm contracts and flattens. At the same time, the pelvic floor muscles are lengthening as the abdominal muscles are expanding. This is what allows us to maintain our intra-abdominal pressure just with breathing at rest. The opposite happens on exhalation. The diaphragm passively rises and the pelvic floor muscles contract and shorten. And this is going on all the time. This is normal with breathing. But as we increase our load or increase our demands on the body and on the core, this becomes even more important so that we can maintain intra-abdominal pressure. So just so you can see that there is evidence supporting this relationship, this isn't just something that we talk about that hasn't been studied. It's pretty well established through the work of Paul Hodges and Carolyn Sapsford in Australia that the transversus abdominis and the pelvic floor work together. And some of the earliest studies go all the way back to the early 2000s. But in 2004, Sapsford proposed that perhaps the diaphragm could be used in addition to the transverse abdominis to retrain the pelvic floor. And so what she found was that in women with incontinence, she could actually retrain breathing and help improve symptoms of incontinence. This was also shown by Hung in 2010. Same thing, a group of women who had a primary complaint of stress urinary incontinence. They incorporated a muscle retraining program that involved the diaphragm, and they showed that symptoms of incontinence improved. Over 4 months, they actually had a 96.7% success rate in the training group. So I consider that a big win. And then Hodges as well showed that there was a connection in 2007 between the diaphragm and the pelvic floor. And there are many more studies just like these. I just highlighted a few that I found to be particularly helpful for me. Likewise, it's been well documented in the literature that the lumbar spine and the pelvic floor are also connected. So again, patients who are experiencing low back pain, we need to consider, is the pelvic floor involved in this? And so this is the same study that I cited on the previous slide about from Hodges, the postural and respiratory function of the pelvic floor muscles. And so he actually looked at what was happening to the pelvic floor when we move our arm. So this is very similar to those old studies with the transverse abdominis where we looked at to see, do these muscles contract in anticipation of movement? And what he found was, just like the transversus and the multifidus, the pelvic floor muscles were contracting in anticipation of movement. The next two studies were done by Smith et al. The first was in 2006. The second was a follow-up study in 2013 using the same cohort. And what this group looked at was what's happening, what are some factors that contribute to women who have low back pain? So in the first study, they looked at a bunch of different factors: obesity, activity level, history of low back pain, etc. And what they found was that there was a strong association in women who have low back pain with not only respiratory problems, but also continence control problems. So they were seeing that there was a direct relationship between these functions and low back pain. In their follow-up study, they took the same cohort and they found that in women who had pre-existing low back pain, they were more likely to develop breathing problems and or incontinence. They also found that women who experienced breathing problems were more likely to develop incontinence and low back pain, and women who were experiencing incontinence were more likely to develop breathing problems and low back pain. So again, further solidifying this relationship between the three. The final study I want to bring up was just from a couple years ago by Dufour et al. And they looked at women who came into the clinic with a primary complaint of low back pain. They found that they examined every woman who came in with a primary complaint of low back pain, and that on examination, 95% of them had at least one clinical finding of pelvic floor dysfunction. So they may not be complaining of pelvic pain or urinary incontinence or constipation or other clinical signs of pelvic floor dysfunction, but they did find there were impairments in the pelvic floor muscles when they did this exam. So this says to me that we can't forget about examining and perhaps treating the pelvic floor. Moving on, the SI joint as well. There's been an established relationship between sacroiliac joint pain and pelvic floor muscle dysfunction. And these were several studies that were done by O'Sullivan and Beals. And they found that in patients who had pain in the sacroiliac joint, when they looked at the active straight leg raise test in these patients, that there was a change in the muscle activation patterns on the involved side compared to the uninvolved side. So they were seeing that muscle activation changes even in the pelvic floor muscles in the presence of sacroiliac joint pain. So again, can't forget about treating the pelvic floor muscles. The last slide I'm going to bring up to kind of bring this all home is the relationship between hip and pelvic floor dysfunction. So I already gave you a couple examples previously, but you can see from these slides that there are a couple other studies that are important to bring up. One by Tanaki et al., which was in 2014, where they had a questionnaire survey of 189 female patients who underwent an anterior approach to a total hip arthroscopy. And they had these patients, they surveyed them before surgery, and then they surveyed them 3 months after surgery. And they found that in the groups that complained of stress urinary incontinence before surgery, after surgery, 64% of those patients improved in their symptoms. So a large percentage of women are getting better in their pelvic floor symptoms after treating the hip joint. Second study was done on men. So this was a case report in 2016 where they looked at a male cyclist with hip and groin pain with prolonged sitting on his bicycle. This patient failed conventional PT, so the traditional strength and mobilization things they would do for the hip and spine only. It wasn't until they added manual, and these were manual techniques, not dry needling. It wasn't until they added manual pelvic floor muscle mobilization techniques that his symptoms began to improve. So when you have a patient who's experiencing hip pain, back pain, sacroiliac pain, and you're not seeing the results you expect, perhaps you need to stop and reconsider what's going on with the pelvic floor. So just to bring it back, I think the obturator internus is probably the key muscle here. So if you do nothing else in terms of dry needling in the pelvic region, this is a muscle you want to focus in on. The technique I have at the end is going to show you a way that you can access the obturator internus through dry needling that does not involve an internal palpation and is quite safe to do. Some of you may already be using this technique, but I find that if nothing else, this is a good go-to one because as you can see in this picture, the obturator internus has some direct relationships into the pelvic floor muscles. But the thing I wanted to bring up on this picture was the slide over here on the right. So this is showing, this is an inferior view, and what's highlighted in green is the obturator internus muscle. This is really important, and it wasn't until I went back and I actually did a cadaver study, actually through Myopain. I did the functional anatomy course with Frank Willard, and we went and looked at cadavers, and the biggest take home for me from that whole weekend was the percentage of the surface area of the obturator internus muscle that's actually located on the internal portion of the muscle. So really all we can access externally is the small piece that's coming out with the other hip lateral rotator muscles and attaching to the greater trochanter. But if we really want to make a difference with this muscle, we need to treat this big internal portion where we see the bulk of the muscle and where likely there are a lot of trigger points located that may be missed if you only treat that external portion of the hip rotators. There's actually a study that I wanted to highlight. This was last year. It was January, April 2018 in the Journal of Women's Health PT. And the reason I bring this one up is because it was the first case report that I saw that actually spoke about using dry needling to treat female chronic pelvic pain. It was a case series, so it was actually 2 women. They were 2 older women. One was 72 and one was 62, and both of these women had a history of chronic pelvic pain. Initially, they were treated, again, with the typical things that you would do in PT: spinal manipulation, mobilization, exercises. They even were taking medications. They had injections, but that was all that they were doing, and these women weren't getting better. They found that each of these women had some other pelvic diagnosis, and they didn't say specifically what that was, but there was some diagnosis in their medical history that clued the clinician in that maybe they needed to look at the pelvic floor. The PT went back and looked at the pelvic floor. They treated both externally and internally, manually, the levator ani muscles and the obturator internus, but then they also performed dry needling of the obturator internus. And this was in both patients. They found that in both of these women, their symptoms were completely gone and their functional mobility was restored within 4 weeks of adding the dry needling component to their treatment plan. So what's interesting about this study is that they never really had traditional pelvic PT before adding the dry needling. They kind of put them both in together. So it's hard to say if it was one or the other or a combination of both. But what we do know is that in these 2 case studies, both of these women did get better with dry needling specifically to the obturator internus muscle. So some other sources of pelvic floor dysfunction besides just the hip and low back and these orthopedic structures, and these are things that you will certainly see in patients and you may notice in their medical history, include athletic pubalgia or groin pain. So for those patients who have athletic pubalgia, perhaps they were diagnosed with a sports hernia, perhaps it's just some groin pain that's not very significant and not improving with the things you are doing. The pelvic floor might be a place to look. In addition, general abdominal pain, even post-abdominal surgeries, and we're going to talk a little bit more about that. But in women who have abdominal surgeries and maybe have some scar tissue or have some difficulty with abdominal mobility, they may start to develop some trigger points in the abdominal muscles as well as in the pelvic floor muscles. Another place this is very common is in irritable bowel syndrome and then also endometriosis. So some two very kind of classic studies that have been done, and these were a number of years ago, by Wesselman had one study and Raghi Dogweiler had another study, and they looked at the relationship of visceral pain, so something like an IBS or an endometriosis, and the presence of myofascial trigger points in the abdominal wall. And they found that if they examined women and these women presented with trigger points in the abdominal wall, 90% of the time that was related to current or past visceral dysfunction. So again, pelvic visceral pain that is referring to musculoskeletal structures in and around the pelvis. This is a phenomenon we call visceral somatic convergence, and we see it a lot in the population of women with chronic pelvic pain. So even though they have a history of things like endometriosis that we may not be able to treat directly with physical therapy, we can treat some of the comorbidities, such as the myofascial pain that goes hand in hand with these disorders, and help these women live more comfortable, less pain, and more active lifestyles. So just to give you some examples of some studies that support the presence of myofascial trigger points in the pelvic floor and as a source of pain, we know that approximately 1/3 of all women experience pelvic pain at some point in their lifetime. So that's just the pain. That's not other types of pelvic floor disorders. Prendergast did a review article in 2017 on vulvar pain, and she cited one study that showed 90% of women who were diagnosed with provoked vestibulodynia had concomitant pelvic floor dysfunction. So again, women with vulvar pain, because of viscerosomatic convergence or other reasons, may also have pelvic floor muscle dysfunction. Also, the vulvodynia guidelines, which were revised in 2015. So this was a multidisciplinary group of clinicians who got together and put together some guidelines to treat vulvodynia and vulvar pain in general, and they list pelvic floor muscle dysfunction as one contributor to vulvodynia. So if you look at their classification system, one of the legs of their classification system of vulvodynia is actually entitled overactive pelvic floor muscle dysfunction. So we're seeing that even outside of the PT world, clinicians are starting to recognize that treating these trigger points in the pelvic floor is important in these intrinsic pelvic floor muscle disorders. So as a reminder, just like other types of pain, chronic pelvic pain is a chronic pain condition. So it involves multidisciplinary treatment. So the physical therapy part of treatment is just one small piece of a greater plan of care. And I want you to appreciate that I'm not saying that dry needling is the only intervention for these patients. Likewise, there's a lot of different reasons why someone may present with chronic pain in the pelvis. So while there is a strong correlation between some of these other disorders and myofascial pelvic pain, that's not the only reason why someone may be experiencing pain. So this is your reminder slide to make sure that you're treating the whole patient and not just being super specific about treating the trigger points and the myofascial pain. So what does the evidence say in terms of treating trigger points in the pelvis? So this is not dry needling specifically. These studies are more manual trigger point studies because there have not been many studies looking at dry needling in the pelvic floor. In fact, that case study that I just mentioned to you might be the only one or one of the only few that I've seen come across my desk. But we find that when we treat these muscles manually with trigger point techniques, patients do really well. So one being very recent, in 2020, so just earlier this year, they compared women with chronic pelvic pain and a set of similar healthy controls. And so they found that in the group with pelvic pain, when they palpated the muscles in and around the hip and pelvic region, they had a lower pressure pain threshold. They had the presence of palpable trigger points in the region. And when they palpated these taut bands in the muscle, they reproduced their system, or their symptoms, excuse me. And in addition, the chronic pelvic pain population also had altered neurodynamics. So it wasn't just about the trigger points, but when they compared these patients with pain to healthy controls, they saw the presence of trigger points in that group and reproducing their symptoms. Anderson in 2006, that group treated a subgroup of men with chronic pelvic pain. So again, not just women. And they saw their interventions included manual trigger point therapy and paradoxical relaxation. And they saw that in that group, there was a moderate to marked improvement in symptoms in 72% of their patients. Fitzgerald in 2012, her group also used a myofascial trigger point approach to treating painful bladder syndrome and interstitial cystitis. They compared just general massage to these specific myofascial trigger point techniques. And they found that in the myofascial group, 59% of women had moderate to marked improvement, where in the general massage group, it was only 26% of women. So there is good support to treat trigger points in the pelvic floor region. If you guys are already treating these regions and dry needling is something that's interest of you, this is a great place to do a study and hopefully build up our vault of papers that help support what we're doing. All right, so the next couple slides I want to go through with you, and we'll go through these kind of quickly so we can finish up and get to some questions, but I wanted to leave you with a few clinical correlations so you could see some specific pelvic floor disorders and what muscles may have associated trigger points so that when you're working with patients, you can think about maybe looking at some of these areas. So the first one I want to talk about is constipation. A lot of people experience constipation. I find that's something we don't talk about enough, but it affects more people than we realize. So some of the common areas that we find trigger points in people with constipation include the puborectalis muscles. So that is one of the layer 3 levator ani muscles, as well as the deep transverse perineal muscles. So that was a layer 2 muscle. So typically if we can get those muscles to relax and let go, and we can treat some of the trigger points in those muscles, people do pretty well. Some other places we may see trigger points in this patient population include the rectus abdominis and the abdominal obliques. So those are not pelvic specific, but are also involved in constipation and in bowel dysfunction in general. With urinary urgency and frequency, this is often related to the lower fibers of the rectus abdominis. In those patients who have a pyramidalis muscle, that is often involved, in addition to the adductor magnus. So the adductor magnus does refer pain to the urethral sphincter, so it will produce that sensation of having to go to the bathroom if there are trigger points in that muscle. In addition, some of those urogenital diaphragm muscles, such as the urethral sphincter, if there's any kind of trigger points or spasm around those muscles, they can also cause symptoms of urgency and frequency. And then what I see often in males, like I said, is that bulbospongiosus muscle. So that is that is often affected in males who have symptoms of urgency and frequency. Coccydynia or tailbone pain. Again, a lot of times this happens because of direct falls onto the tailbone, so there is a direct trauma there. So really any muscle that attaches to the coccyx could reproduce coccydynia. So the gluteus maximus muscle, the coccygeus muscle, the other levator ani muscles, so those deep pelvic floor muscles. But other muscles, including the obturator internus and the quadratus lumborum, also refer pain to the coccyx. So making sure we look at those muscle groups as well. Vulvar pain. So vulvar pain is kind of a pain of unknown origin in the vulvar region in females. And there's a lot of different things that can affect pain in that region. So it's not just one muscle group. This is very kind of multitude of things, including neurogenic pain, including hormonal pain, including myofascial pain and trigger points. So I find that often in this group of patients, a lot of the trigger points are very specific in the pelvic floor. So all three layers, including the bulbospongiosus, the ischiocavernosus, the superficial transverse perineal muscle, the perineum and the perineal body are often tight, and sometimes that's a good area to do a little bit of dry needling. And then even some of the deeper pelvic floor muscles, such as the levator ani muscles, are often implicated in this group as well. And just because we talked about vulvar pain in women, I wanted to make sure I brought up prostatitis in men. So there is a group of prostatitis. It's previously known as chronic non-bacterial prostatitis. It's what we most commonly call chronic pelvic pain in men. So often they believe that they have an infection, but in the absence of infection, there's still a lot of pain in this region. And again, these muscles typically involved include any of the muscles in and around the pelvis, especially, like I said, in males. The bulbospongiosus seems to be a big player, even in this group, as well as the levator ani muscles. So then the question comes, how do we know when to perform dry needling in the pelvic floor and when not to perform dry needling in the pelvic floor? So I think this is a really valuable question to ask, because when we talk about the pelvic floor region, it's a very sensitive region. So societally, people don't like to talk about it. Somebody might feel embarrassed. They may experience shame because they're having pain in this region. It may not be something they want to share with you, and it may be something that they really feel uncomfortable about. It can be very scary for patients who are experiencing pain in the pelvis to want to have even the monofilament needles that we use with dry needling, to place them in that region might be very anxiety provoking for patients. So I always put that out there that this may, while this can be beneficial for all of these patients, this may not be the first treatment that I choose. I think the best approach to deciding when you're going to be performing dry needling with some of these patients is do your internal examination first. I think it's very important that if you're going to be needling in and around the pelvic floor, you have first done an internal pelvic exam so that you are aware of where their pain and where their reproduction may be. Even though with some of the techniques that we use to dry needle in the pelvic floor, we are using an internal palpation at the same time. And that's one unique thing about needling in this area, is that because you can't really palpate these muscles externally, you have to use an internal palpation to make sure that you know that your needle is where you think it is. But it also becomes important that you're assessing these muscles just like you would assess any other muscles. So in the pelvic floor, that means doing the internal examination first. But there are going to be patients who don't have a high tolerance for an internal exam. I have a patient right now who has very high sensitivity when it comes to internal exams. She's a great person and a great candidate for dry needling because I know that there are trigger points in those muscles that we need to treat, but I'm not going to be able to do any kind of internal manual work with her. So I may choose the dry needling route to give me another option to work on these muscles that's going to make her feel a little bit more comfortable. I think any patient that's had a history of abuse, that's another place we kind of have to go when we're treating the pelvic region. Is there's a high percentage of patients with pelvic pain who also have a history of abuse, and so they may not feel comfortable with dry needling in that region, and that's really okay. I also think that some patients who maybe have a strong central component to their pain, this may not be my first intervention of choice. I find that dry needling in the pelvic region typically works very well in more acute pain situations. So my postnatal population, women that have had babies and are having some pelvic floor pain after delivery, do really well with these techniques. Women who have had episiotomies or who maybe tore during delivery and have had some stitches and have some scar tissue that's affecting muscle function, they do really well with these techniques. Men do really well with dry needling and the pelvic floor techniques because a lot of their dysfunction tends to be in those more superficial anterior muscles, and those are just very hard to access through a rectal palpation of males of their pelvic floor. So I find that they are usually more amenable to doing dry needling, and these techniques work really well with that group. But as a summary, I would make sure that you have patient consent, you've done an exam so you know which muscles you want to needle, because you're not going to spend a lot of time needling in these areas. It's a very highly innervated area, so it's going to be typically a get in and get out kind of quickly sort of thing. And like I said, that you have patient permission, and that's where I would start in terms of dry needling the pelvic floor. All right, so the last slide, I'm leaving you with this so you can just see, and the technique, one of the techniques that we're using, and this is not an internal technique, which is why I put it in this webinar, because I recognize that not all of you are doing internal pelvic floor work right now. And if you're not, this is probably not, you don't want to start with internal techniques. I would encourage you to maybe take a course to learn some of the basics of an internal pelvic floor musculoskeletal exam before venturing into dry needling these structures. But the obturator internus, this is probably one of the best ways to needle the obturator internus. And if you have Dr. Dommerholtz's textbook, the latest edition of the textbook does have this technique in it, and several other photos and descriptions of dry needling in the pelvic floor techniques. If you feel pretty comfortable in this region and you maybe just want to look at some of these, you're more than welcome to do that. But you can see for this technique, your patient is lying with the affected side down. And what we are doing is we're palpating that part of the obturator internus where it comes over the ischial tuberosity and kind of dives deep. So if you're palpating up, what I typically recommend is that you find the ischial tuberosity coming from the thigh, so coming up inferiorly, find the ischial tuberosity, and then what you can do is just slide your fingers over that bone, and you should be able to palpate perpendicular to the muscle fibers in that region. If you can find that, and sometimes you will need the patient to kind of hold their buttock out of the way on the upper cheek, you can palpate on the trigger point right there and place the needle directly perpendicular to the trigger point. So that is one of the best ways, I think, to start to get into that internal portion of the obturator internus. You maybe can also, at slightly no more than a 30-degree angle, take it toward that medial portion of the ischial tuberosity, because it is pretty thick in that region. And so you're really just needling down into the bone, and you can start to get some of those fibers of the obturator internus as it starts to spread and fan out into that internal pelvic region. So I would start with that technique, and then if this is something that interests you, we will hopefully be offering some pelvic floor dry needling courses later this year, and I would love to see all of you there if you're able to make it. I'm going to go ahead and open up the questions at this point. Use of ultrasound for pelvic floor dry needling should be mandatory or not. I think using the ultrasound is a fantastic thing to do if you're trained. So here in the US, not every physical therapist is trained in the use of the ultrasound, so we have not made it mandatory. But I think if you have training in the ultrasound for the pelvic floor and you can use it, I think that's a fantastic tool. It's probably, it may even be better than, I mean, I still like the palpation, but I think being able to visualize that way would make it so much easier. So that's a great question, and I'm glad that you are all, it says in Latvia, we must use ultrasound for pelvic floor dry needling. So that's not a requirement here in US, but I really, really like that idea. So thank you for bringing that up. Is it possible to receive the links for the articles related? I can give you the citations. I can't give you full articles, but I'm happy to give you the citations if you want to look them up yourself. We can do that. What is the S in continence? So the S is sphincter control. So I mentioned there were 4 S's in pelvic floor function: support, stability, sexual function, and sphincter control. So continence is sphincter control. It's the urinary or the urethral sphincter and then the anal sphincter as well. All right, so for women who prefer non-surgical solutions for pelvic organ prolapse, would you recommend dry needling? And for women who choose surgery, how dry needling may be used post-op? Those are great questions also. So pelvic organ prolapse. So dry needling may be indicated, and I think it's going to depend on your clinical exam. So when we're dealing with pelvic organ prolapse, that's typically an issue of poor maintenance of intra-abdominal pressure. So usually the abdominal pressure is greater than the pelvic pressure, and the result is that the pelvic organs can then begin to prolapse or herniate into the walls of the vagina or rectum in the case of a rectocele. So what I find clinically, and this is purely anecdotally, is sometimes in women who experience pelvic organ prolapse, there are associated trigger points in the muscles in the pelvic floor because those muscles are working so hard to help maintain intra-abdominal pressure. So if you can imagine, you've got this downward pressure from the abdomen and these organs are pushing down, and the pelvic floor is working really hard to keep those organs from herniating. Those muscles then become overworked and may stay contracted, may not be able to release their contraction, and they may become hypoxic in that region and develop trigger points. So I think that if you are doing a clinical exam of a patient with pelvic organ prolapse and you notice that she has trigger points in the pelvic floor, I think that is a great option. But it's also important to remember that after you do your dry needling to the trigger points, you still have to retrain the muscle coordination, the muscle control, and teach her how to maintain her intra-abdominal pressure. So it's a way to get into the muscles to help them respond a little bit better, but in terms of helping to support the prolapse, they still need the muscle retraining piece of that. I would argue the same in the post-surgical population because they've probably had some dysfunction even prior to going into surgery. So you may find that there are still trigger points. You do have to be careful post-surgically. I would say absolutely in the first 6 weeks post-surgery, I would not dry needle in the pelvic floor. I would let that tissue heal, and I would make sure that you get clearance from the surgeon at that point just to be safe in terms of doing dry needling. But there's, other than those precautions, you can absolutely dry needle post-operatively. All right, it is 6:02. I've got several more questions, so I'm going to try to go through them really quickly. I understand if people need to get off, but feel free to stay on if you can. And for those of you who need to get off on the replay, you will get the answer to these questions as well. So next question is, do you have experience with scar tissue dry needling in the pelvic floor? And what happens with the motor function of the pelvic floor muscles after treating the scar tissue? Dry needling is a fantastic technique for scar tissue. I find the 2 areas I use it the most in this population is with perineal scars after childbirth and also with C-section scars after childbirth. So I find that that motor function of the muscles absolutely improves, because as we know, when we release trigger points, and even in that scar region, when we're able to kind of give more neural input into the tissue as we're needling through the scars, that kind of helps that brain to muscle, that nervous system connection, and I find that muscles tend to activate a lot better. So it becomes a lot easier to start to retrain those muscles once I've worked and dry needled through some of the scar tissue. All right, so given the depth of the pelvic floor muscles, what's the needle length you normally use? I usually use the 50 millimeter needles, the 0.3 by 50. There's some, if you're going really deep, you may not reach them, but I'm doing this technique. The dry needling techniques look very similar to this one that's up on the slide right now, this Obturator internus technique. So I'm approaching it more from the posterior aspect of the pelvic floor. So I don't need to go quite as deep as I would, say, if I were going in from the anterior aspect of the pelvic floor. I find that the 50 millimeter gives me enough length that I can access the muscles, but still gives me enough control of the needle so that I can really feel what's going on. I find that any longer, they tend to bend, especially because there's so much soft tissue in this region, and it's harder for me to have control of what I'm doing. And I always like to make sure I know exactly where I am and what I'm doing when I'm dry needling, especially in this region. All right. Can you explain how you dry needle iliococcygeus? Sure. So you can see this picture of Obturator internus. The iliococcygeus technique is going to look very similar to this. I use a rectal palpation when I dry needle the levator ani muscles. I find I like this sideline position. I find it's very comfortable for the patient. They're not, it's hard because you can't see their face, but they're not looking at you coming at them with a needle. So I find it's a little more comfortable for them to sit in this position. And I keep the affected side down. So I'm always going down. I'm always angling my needle slightly inferiorly toward the table. I'm doing a rectal palpation. So in my non-needling hand, I am palpating through the rectum to find the trigger point in the iliococcygeus that I want to needle. So if I go in rectally, and if you're going to iliococcygeus, it's kind of like in and down. So I'm coming in and down. I'm keeping my finger at that spot, and then I'm taking my needle, which you can see on this Obturator internus section, it's slightly posterior. So I would want to come maybe a little bit more anteriorly here, and I'm angling the needle. It's inferiorly and medially, but it's more inferior than medial. So I don't want to come in this way because I could get to the rectum and that's not very safe. So I'm coming inferiorly and medially down into the iliococcygeus muscle, and I'm aiming for my finger. So that is why I advocate for using an internal palpation at the same time. It's definitely a more advanced needling technique, but it allows you to really know where you are in terms of orienting yourself to the pelvic floor muscles themselves. And like I said, if you have the textbook, that technique is very clearly explained in the textbook as well, just like that. Oh shoot. Okay, so how do you do dry needling to the pubovisceral muscle or the deep transverse? Okay, so pubovisceral is going to be very similar to iliococcygeus. I'm just going to shift my palpation of my internal finger to where I can palpate the pubovisceral muscle, or what we sometimes call the puborectalis muscle. So I'm moving my finger more medially, so I'm palpating that muscle. And then my needle angle, instead of being more inferior, I'm going to bring it up slightly more anterior and medial so that I can meet that muscle. So iliococcygeus is more this angle, where pubococcygeus is more this angle. Deep transverse, I'm doing from an anterior approach, and I use a pincer palpation in females. You can't really do that in males because they don't have the vaginal opening anteriorly like we do in females, but I'm hooking one finger through the vagina and palpating posterior on the posterior aspect of that deep transverse muscle using a pincer palpation through both the superficial and deep transverse muscle. I'm then needling from an anterior to posterior direction straight back toward my finger. So that would be done, the patient would be in the supine lithotomy position to do that one. How many applications of dry needling do you do on average? So do you mean, so in one session, I may do maybe 2 or 3 different regions of the obturator internus in one session. I think in terms of how many times I do it, it depends on the patient. Sometimes I can do 1 and they're great. Sometimes I may have to do 4 or 5 times and it may take a little bit longer depending on the patient, depending on the chronicity of their symptoms, depending on their tolerance level for the dry needling. So there's not really one answer for that. How soon postpartum can you perform dry needling of the pelvic floor? So I like to wait a minimum of 4 weeks, and that's usually in patients that I saw them during pregnancy. I will wait because they're familiar with me and I have a relationship with them. If it's a new patient, I probably would not start dry needling until they had their postpartum follow-up with their obstetrician. Again, I think at the 4 to 6 week mark, the tissue is probably healed, with the exception of if they have any kind of sutures from an episiotomy or a perineal tear. I would maybe wait closer to the 6 to 8 week mark at that point, just to give the tissue time to heal. But if it's just a normal vaginal delivery without tearing and you want to dry needle the pelvic floor muscles, I would say if you really want to play it safe, about 6 weeks or after they've had their postpartum visit with their obstetrician and you know that there are no other complications going on. Do I ever dry needle on the shaft of the penis to get the bulbospongiosis? No, I do not needle on the shaft of the penis. I think it's so highly innervated and there's so many other vascular structures there. I don't think that's particularly safe to do so. I tend to stay more at the base of the bulbospongiosis, kind of closer to the perineal body. I think that's a much safer region to needle. How can we use this with a ticklish patient? So again, I think that's just knowing your patient and maybe using some techniques that you would use to kind of decrease sensitivity in general, whether it's using some manual techniques first, or maybe a lot of times I'll just use like firm touch. So you can see in this picture I have up there now that I'm in my palpating hand, I'll use very firm touch so that they can feel that instead, and sometimes that will reduce the neural input and help to reduce some of the sensations of being ticklish. Already addressed that one. So can we needle the external portion of the obturator internus, and does it help with pelvic floor dysfunction? Absolutely you can, and absolutely it can, and if that's where you feel comfortable, I would do that. The point I was just trying to make is that I feel that the bulk of the muscle surface area tends to be in the internal portion. So I think the most complete treatment is needling the internal as well as the external portion. But if all you know how to do and all you feel comfortable doing is that external portion, absolutely. How am I cleaning the ischio cavernosus on women? So I typically don't. You know, I think you could use just like a wipe, like an obstetric wipe, not an obstetric wipe, but just like a wet wipe that you would use with your patients after you did an internal treatment. If you felt like you needed to clean the skin, you could have them just use the restroom and hand them a wipe and have them wipe, or you could leave the room and just have them wipe in the treatment room as well if that was something you felt like you needed to do. I find that typically that area is fairly clean. I don't repeatedly needle in that area. It's usually a one needle and then I discard the needle, and then that does kind of help in terms of transmitting things as well through the region. I don't use, this question says, do you use electrical stimulation to needle muscles, to needle in the pelvic floor? I don't think that it's a definite hard no. I just think it's a really sensitive area, and so I just prefer not to in that region. I do use it in other parts of the body, just not there. So patients with hemorrhoids, that's a really good question too. I actually think if the hemorrhoids are external, I think you just have to be aware, or even if they're internal and you can palpate them, you obviously don't want to needle directly into a hemorrhoid. So because a hemorrhoid is kind of like an outpouching of the blood vessels. So you don't want to needle into a hemorrhoid, but if you can see them and if you can or feel them and maneuver around them, I think dry needling is actually a great technique, because I find that in patients with hemorrhoids, the manual techniques through the rectum tend to be very uncomfortable. So this might be actually a good alternative in those patients. Are there any concerns with affecting the pudendal nerve? Minimal. I think the big areas are the Alcock's canal region. So I think you just have to be careful not to get too far anterior when you're palpating to needle, that you're not catching the nerve where it's coming through Alcock's canal. And then the other region is when you're needling the urogenital muscles, to just make sure, because that is a highly innervated region and the branches of the pudendal nerve do run through there. I tend to stay in and around the ischial tuberosity when I'm needling in the urogenital triangle, just so I know where I am and I can needle into bone, and then I can feel a little bit more comfortable about minimizing the risk of needling the pudendal nerve. All right. Is it possible that it could puncture the bladder? If you're needling in the pelvic floor, that likely will not happen. That is part of the reason why I advocate for doing an internal palpation, because if you can feel where you want to needle with your finger and you're needling directly towards your finger as your backdrop, you will not puncture the urinary bladder. If you go straight medially this way, it certainly is a possibility. So I would encourage you to make sure you're needling inferiorly down toward the treatment table to avoid that. And then if you're needling up around the pubic region, you have the pubic bone, the superior part of the pubic bone is right there. So you can use the pubic bone as your backdrop and needle into the bone versus going straight AP and coming down in toward the bladder. It's probably, if you're using the right techniques, it's very, very low risk that you're going to needle the bladder. Are you concerned about needle stick injuries? Not necessarily, because I think, again, if you have palpated your patient and you're familiar with what their body feels like, and you take it a little bit slowly with that pincer palpation, you're going to feel the pressure of the needle coming toward your finger long before the needle's actually going to hit your finger. So again, the finger is just a guideline of where you want to guide the needle. It's not your hard stop point. So you're not going to your finger, you're coming toward your finger, if that makes sense. Okay. Those were really good questions, and I flew through them very quickly just to be mindful of time. So I appreciate your time. I appreciate those of you who could stick around. I'm happy to stay on for another 3 or 4 minutes if anybody has any additional questions. If not, thank you so much for your listening and for your time. And I look forward to seeing you in a course soon. Have a great night.